Hello everyone, I'm Dr. Sakshi Sethia. I'm a pediatric cardiology resident and this is my YouTube channel. I intend to upload one lecture per week on my channel pertaining to pediatrics or cardiology related topics. Please don't forget to subscribe to my channel if you haven't already. In this particular lecture, we'll be discussing about thiamine under the following headings. We'll first begin with a very basic overview of the related biochemistry, followed by dietary sources of thiamine, deficiency states and their clinical manifestations, labs, and finally how to treat a deficiency state. Very tangentially speaking, thiamine helps in three processes: carbohydrate metabolism, nucleic acid synthesis, and synthesis of neurotransmitters, thus helping in nerve conduction. If we look at carbohydrate metabolism, we have glycolysis and an alternative pathway called HMP shunt. So there is glycolytic pathway and pentose phosphate pathway, also known as hexose monophosphate shunt pathway. In glycolysis, glucose gets converted into pyruvic acid, which enters the link reaction. So this pyruvic acid or pyruvate enters link reaction, which basically converts pyruvic acid into acetyl coenzyme A. And this is the particular reaction wherein thiamine is used in the form of thiamine pyrophosphate, which is the active form of thiamine. The alternative pathway of glucose metabolism is HMP shunt. While glycolysis is purely a catabolic process, HMP shunt has both catabolic plus anabolic phases. The catabolic phase produces NADPH, which is further utilized in the synthesis of fatty acids for glutathione reduction and for other reactions such as neurotransmitter synthesis. The anabolic phase, on the other hand, it forms pentose sugars which are consumed in making nucleotides. And thiamine is basically used in both catabolic as well as anabolic phases. That's basically a very brief overview about the biochemical reactions where thiamine is required. You can always build upon it by reading through any biochemistry textbook. Now, coming to the dietary sources of thiamine, as we know that it's mainly concerned with carbohydrate metabolism, it is logical to think that carbs should be packaged with a machinery to metabolize them. Here we can see we have a wheat kernel. So in this wheat kernel, which is a cereal and is enriched with carbohydrates, its bran or the outer covering is enriched with thiamine. And similarly, other cereals such as rice, oats, when we talk about cereals, we're talking about whole cereals, whole grains. So these whole grains are rich source of carbohydrate as well as a rich source of thiamine if consumed as whole grains. And you should know that thiamine is a water-soluble, heat-labile vitamin. And therefore, we all are aware of the process of parboiling, which preserves the amount of thiamine in rice, which otherwise would be lost if the water is refused. You should also know that coffee and tea, they are both antagonists of thiamine, and fermented fish contains thiaminases, thus contributing to a deficiency state of thiamine. Other sources of thiamine basically are legumes, nuts, pork, fish, and poultry. Now, when all should we expect a deficiency state? If carbs are consumed in an extremely high amount, we fall short of the metabolizing machinery. Again, in a very hypermetabolic state like hyperthyroidism, pyrexia, increased muscular activity, pregnancy, lactation, malignancy, and in post-op period, we should expect a thiamine deficiency. We had a kid in our PICU. The kid was a case of perforation peritonitis who underwent ileostomy and in post-op period developed peripheral neuropathy as a feature of dry beriberi and responded very well to thiamine supplementation. So that's something to keep in mind. You should have a very high index of suspicion for a deficiency state to basically give a proper and adequate treatment. Then again, a severely malnourished state, we'll expect a macro plus micronutrient deficiency. Then a diet which is enriched only with polished rice, white rice, and very refined wheat flour or certain food faddists will develop a deficiency of thiamine. Alcoholics, because of their poor feeding habits and because of gastritis, which impairs absorption, they will develop a deficiency. And then lastly, we have congenital disorders associated with thiamine metabolism, which we'll be discussing in the coming slides. But before that, let's move on to the clinical manifestations of deficiency state. To begin with, there are no specific features. The patient will present with fatigue, apathy, depression, poor concentration, drowsiness, anorexia, nausea, abdominal discomfort. All of this does not point to any particular systemic involvement. It is very generalized. But if the deficiency is prolonged, then the patient will develop specific features pertaining to either nerve involvement or cardiac involvement. And most of the patients, in fact, have a mixed involvement, wherein there are components of neuropathy as well as water retention both. If we talk about the neuritic form, we are all aware about the paresthesias, the tingling, burning sensations. But the neuritic form or the dry beriberi is not just limited to, we should think beyond paresthesias. The patient will also have a decreased deep tendon reflex. There can be a loss of vibratory sense. There can be cranial nerve involvement in form of ptosis and hoarseness of voice, aphonia. And there could be subtle psychological disturbances which could be otherwise ignored. If the deficiency state is very, very prolonged, the patient could have ataxia, increased ICT, meningismus, and ultimately it can even lead to a comatose state. Whereas in wet beriberi, there is a lot of fluid retention, but what is to be noted is that the fluid retention is not just because of cardiac involvement. It's not just heart failure which causes all the fluid retention. There's also a component of renal dysfunction which happens in dry beriberi. Another classic manifestation of thiamine deficiency state is Wernicke's encephalopathy. As we all know, Wernicke's encephalopathy is a triad of altered mentation, ocular manifestations, and ataxia, but it is very rarely reported in infants and young children. Maybe only with a very severe deficiency which happens only secondary to malignancies, or maybe when the baby is being fed with a defective formula will the child present with Wernicke's encephalopathy. Next deficiency state is the congenital disorders which are associated with thiamine metabolism. We'll briefly discuss the important ones in the coming slides. So we have thiamine-responsive megaloblastic anemia syndrome, biotin and thiamine-responsive basal ganglia disease, type 1 diabetes mellitus. It being a carbohydrate metabolism disorder, it has been seen that these kids, if supplemented with thiamine, they have a better glycemic control. Then we have Leigh encephalomyelopathy and thiamine-responsive pulmonary artery hypertension. This is very important. First, we'll discuss about thiamine-responsive megaloblastic anemia syndrome. It is a triad of megaloblastic anemia, sensory neural hearing loss, and non-type 1 diabetes mellitus. The defect lies in thiamine transporter called SLC19A2. It is a soluble carrier protein. You suspect this disease when there is a megaloblastic blood picture in the absence of B12 or folate deficiency. And plus minus the other two features, SNHL or non-type 1 diabetes. The thing to note is that these two features, megaloblastic anemia and diabetes, they both improve with thiamine supplementation. However, neuropathy, once established, once developed, it will not improve despite thiamine supplementation. The next disorder is biotin and thiamine-responsive basal ganglia disease. There is a carrier protein involved in this. The defective carrier protein here is called SLC19A3. Again, a soluble carrier protein of thiamine. Back there we had SLC19A2. Here we have SLC19A3. This disorder is characterized by recurrent episodes of acute or subacute encephalopathy. If we look at, in this acute and subacute encephalopathy, there are features which are always present, features of extrapyramidal networks. If we look at this particular CT, we'll see bilateral diffuse hypodensity of putamen, and follow-up MRI of the same patient was done, wherein we can see bilateral atrophy of putamen, even caudate nucleus. So there is always an involvement of basal ganglia, and therefore the clinical picture of extrapyramidal symptoms are always present. A similar clinical picture and a similar brain neuroimaging picture is also seen in Leigh encephalomyelopathy. Leigh encephalomyelopathy is basically a mitochondriopathy. When we talk about mitochondriopathy, we are talking about a disorder which relates with oxidative phosphorylation which has gone wrong. And when we talk about thiamine is also involved in an energy generating process, basically involved in the link reaction. So if the link reaction doesn't happen, ETC will not happen and ATP will not be produced. And it has been seen that thiamine supplementation has been associated with a symptomatic improvement in these patients who have encephalomyopathy. Since it is a mitochondriopathy, it will affect all the metabolically highly active tissues and organs, and therefore we have a CNS involvement, we have cardiomyopathy, and we have GI involvement and other involvements like renal dysfunction, SNHL, hematological blood pressure, and etc. etc. The next disorder is thiamine-responsive pulmonary artery hypertension. This is very important and it is a very common presentation in our Indian setup. Hasn't been much seen in West. It is seen in post-neonatal period. So it is different from PPHN, which is seen in neonatal period. In the post-neonatal period, it is triggered by a respiratory tract infection, group pertussis or anything. It's basically, it has been observed that most of the times there has been a trigger of RTI, following which the child ends up in pulmonary hypertension, right heart failure symptoms. These infants usually are well-nourished, breastfed infants. These infants look well and have always been well before they land up in pulmonary hypertension. There is a history of exclusive breastfeeding, and the mother has been consuming polished white rice based diet, and the mother is basically having a subclinical thiamine deficiency. The child, being very metabolically active in this particular age, presents clinically with overt thiamine deficiency. Why does this happen? There are two mechanisms by which pulmonary hypertension develops. As we know, thiamine deficiency, it causes a state of acquired mitochondriopathy. So we have a failure of Krebs cycle and ETC leading to less and less ATP production. Because there will be less and less ATP production, there will be more and more adenosine, which will lead to systemic vasodilation, systemic hypotension, and ultimately will lead to a high output left-sided heart failure. This leads to increased LVEDP, and this increased LVEDP further causes pulmonary venous hypertension, which ultimately leads on to pulmonary arterial hypertension and right heart failure. Then, because there is an energy failure, there will be a lot of lactic acidosis, and this lactic acidosis itself is a potent pulmonary arteriolar constrictor leading to pulmonary arterial hypertension. And again, because there is an energy failure primarily, there will be myocardial depression and dysfunction. And it has been seen that this myocardial dysfunction in an infantile age is more severely affecting right heart compared to left heart, and therefore we have a picture of pulmonary arterial hypertension. The second mechanism is reactive oxygen species or free radical formation. Whenever there is a thiamine deficiency state, there's a lot of free radical formation which converts nitric oxide into peroxynitrite. Now we know nitric oxide is a vasodilator, but peroxynitrite, it is a potent vasoconstrictor, and this leads to pulmonary vasoconstriction leading to pulmonary arterial hypertension, ultimately leading to right heart failure. In many of these cases, there is a history of previous sibling having similar clinical picture around the same age, which either points that there is a genetic predisposition to develop pulmonary hypertension, or the mother has been having a persistent state of thiamine deficiency since ever. If you look at this particular case, in this chest x-ray of a 2.5-month-old kid who clinically presented with respiratory distress and peripheral edema following an episode of respiratory tract infection, we can see bilateral haziness in the lung fields, and CTR is approximately 60%. Upon doing an echocardiographic evaluation, we can see that RARV is dilated, and there is flattening of interventricular septum suggesting increased right-sided pressures. And on doing a Doppler imaging, we can see there's a tricuspid regurgitation jet. This kid was started on pulmonary vasodilators but did not substantially respond to the vasodilators until thiamine was infused at a dose of 100 mg over 1 hour. The child responded drastically to this. This is one way of objectively diagnosing thiamine deficiency and thiamine-responsive pulmonary artery hypertension. Otherwise, the standard laboratory assay basically measures something called as RBC transketolase activity. Now, we all know that in RBC, glucose, most of the glucose undergoes glycolytic pathway. But 5 to 10% of glucose via glucose 6-phosphate is acted upon by G6PD, and it enters the HMP shunt, wherein it is acted upon by the enzyme transketolase. this transcrystallase requires thiamine as a cofactor. If there is a thiamine deficiency, we'll see the RBC transcrystallase activity will be very low. And if we measure this transcrystallase activity after supplementing thiamine pyrophosphate, and in comparison to the activity level without giving TPP, if the activity increases by 15%, it is called a significant increase and signifies that there was a deficiency to begin with. This is called increased thiamine pyrophosphate effect. If the increase is up to 30%, it signifies a severe thiamine deficiency to begin with. Now, how to treat this deficiency state? Whenever we have a neuritic form, a cardiac form, or a mixed picture, we need to start with parenteral dose, which is 10 mg per day for 1 week, followed by per oral dose 3 to 5 mg per day. It is 3 to 5 mg per day for 6 weeks. And the cardiac response is drastic and dramatic, whereas if it was a nerve disease to begin with, the response is often slow and incomplete, especially when we are talking about infantile age. And the survivors of severe infantile thiamine deficiency, they usually have a residual neuritic form or residual debilitation after getting cured of the acute episode. Lastly, if you're talking about thiamine-responsive megaloblastic anemia or other dependency states like biotin and thiamine-responsive basal ganglia disease, they basically require higher doses to the order of 100 to 200 mg per day, and the treatment is lifelong. So that's all about thiamine. I hope these concepts will be very helpful for you in your practice, and you can keep revising them from the lecture. Thank you.